So, good evening, all. Today, I will be discussing some points from this journal article titled 360-degree laser versus localized retinopexy in the surgical management of primary rhegmatogenous retinal detachment using pars plana vitrectomy. The moderator of this class is Dr. PDS, sir. So, the overview of the presentation I have divided into 4 sections. First, we'll understand the research question and the outcomes of the article. Then, we'll understand what are the research methods they employ to get to the conclusion. Then, the mechanisms of 360-degree laser versus focal or localized laser, how it affects the outcome, and then the consensus. So, ultimately, what to be done when you encounter such scenarios. So first, what was the primary research question of the article? So it was that does 360-degree endo laser circlage reduce the risk of redetachment compared to a localized retinopexy in management of primary rhegmatogenous retinal detachment treated with pars plana vitrectomy? So the study hypothesized that the 360-degree laser retinopexy creates a complete barrier preventing peripheral breaks and decreases the chance of redetachment compared to a localized retinopexy. They expected a reduced redetachment rate. So the study was conducted in Switzerland. It was a tertiary referral center. The study period was around 4 to 5 years. Follow-up was done post-surgery for 1 year. They followed up all the patients to check for the occurrence of redetachment. Total 973 eyes were enrolled which underwent pars plana vitrectomy. So the study inclusions were primary rhegmatogenous retinal detachment treated with vitrectomy only, first time undergoing RD surgery, and they had a complete surgical follow-up till the follow-up period of 1 year. Minimum follow-up period achieved is 1 year, so till that they included. Exclusions were previous surgery, secondary detachment like tractional, exudative, or maybe after first pars plana surgery, traumatic detachment, incomplete surgical record, and loss to follow. So they did 23 standard 23 gauge pars plana vitrectomy in all cases. Steps were as routine like core vitrectomy, base shaving, reattachment using fluid air exchange or PFCL assisted, retinopexy either localized with laser or cryo or combined. So they do localized retinopexy either with laser or cryo or both, or they did 360-degree with treating the focal lesions as well. And tamponade was either gas, short acting or long acting, and silicone oil. All this were dependent on the operating surgeon. So there was around 6 surgeons included in the study. So what they did in their localized retinopexy, they treated the retinal breaks or did external cryo or both. And in 360 endo laser, they did 2 to 3 confluent rows of laser immediately posterior to the vitreous base, and it was continuous. Additional localized treatment of breaks, lattices or other lesions were done as and when needed. So these are the results. They enrolled 973 eyes, out of which 662, almost 68%, were treated eventually with localized retinopexy, whereas the other with 360-degree circlage. Subgroup analysis, you can see here, left side, local retinopexy. Out of them, only laser, only cryo, or both. So these are the divisions. And in the 360-degree group, only circlage or circlage with additional treatment. So this is not very important, just for you to see. The other characteristics of the demographic were male, mean age, macula of primary, PVR, silicone oil. All these were not equally divided between the two groups. As you can see here, the 360-degree circlage patients, more number of patients had macula of detachment, more patients had primary PVR, more patients were treated with silicone oil compared to the other group. So here you can start seeing some discrepancy in the results. However, these differences were statistically significant. So what were their results? So what they wanted to measure was the redetachment rate in both the groups and time to redetachment. So after 1 year of their follow-up, how many patients did not detach and how many patients had detachment in either groups. So the redetachment rate overall was 7%. So 68 eyes out of the 973. 8.5% within the localized retinopexy detached and 3.9 in the 360-degree laser group. So here you can see that almost 50% less patients redetached in the 360-degree laser group, which is statistically significant also. And 4.6% absolute and 54% relative risk reduction. So 8.5 minus 3.9 is around 4.6 absolute reduction compared to local retinopexy and 54% relative. So almost half reduction in the 360-degree group. However, this is just a crude analysis. This is simple percentage and mathematics. This does not account for all the other differences that eventually they tested for. Other was time to redetachment. So how many patient from the day of surgery redetachment occur at what interval? So they followed up all the patients for 1 year. So it is kind of a survival analysis. And in statistics, we do Kaplan-Meier survival analysis to find out how many patients at the end of the follow-up they survived. That means they did not have redetachment. So the mean time of redetachment was 28 days, which has a large variation from 3 to 336 days. And the hazard ratio, which was unadjusted. So how many patients survived was 0.44%. So meaning that 360-degree group had 56% of lower hazard compared to localized group for redetachment. Still it is unadjusted, so it doesn't account for baseline severity differences. So what is the dilemma here? The major concern is confounding by indication. As we saw earlier that the cases treated with 360-degree cerclage had higher risk characteristics at baseline. So does this affect the outcome? Surgeon chooses the 360-degree laser based on the intraoperative findings for more complex cases. So this can be adjusted by statistics or not. We will see that. So now we'll understand what statistical methods they employed to rule out as many confounding factors as they could. So first, if you go through the study, they have explained this in very detail. First, they did power analysis. So what they did is, before starting, they estimated how many eyes they need to have a statistically significant result. So they expected that 1/3 of the eyes would get in 360-degree group and rest would go into the localized group based on their practice. And they estimated using a software that they found that they need to enroll about 1,000 eyes for their study to have a 76% chance of detecting a meaningful difference. Meaningful as in statistically p-value should be less than 0.05. So first they wanted to enroll this many eyes, they enrolled 973 eyes. Second, they did descriptive stats, as you know, age, sex, how many PVR, macula of status, all that we do in our studies also. This helps us understand what the population that we are dealing with. Third, they did primary outcome, which was the percentage of patients with redetachment and time to redetachment. So here they used a Cox proportional hazard model. This is often used as survival analysis, as I told you. It calculates two things. First is the hazard ratio. Hazard ratio is the chance of a redetachment occurring at any time point in one group compared to the other. And the Kaplan-Meier curve, which shows the survival over the period of follow-up. So here the study found that the hazard ratio for 360-degree laser, so our encirclage, was 0.44%, meaning that the risk was more than halved compared to the other group. So here is the Kaplan-Meier survival graph from the article. You can see the blue one is the endo laser encirclage and the brown one is the localized retinopexy. So you can see the 360-degree graph is slightly higher compared to the other graph. Higher is the probability. On the y-axis, you can see the survival probability. So 100% of the patients survived at the day of operation. So no detachment at the end of surgery. As you go through the follow-up of 350 days, so around 1 year, patients started getting redetachment. Can you see the pointer? Yeah. So here at the beginning, these are the 973 patients. None of them had detachment. As you go through the follow-up over the year, you can see this in 666 of the 360-degree of the localized retinopexy. Only 600 survived at the end of the follow-up. So around 55 to 60 patients had detachment. Compared to the other group, out of 311, 299 survived. So only 12 patients had detachment. So this is the survival analysis that they did. Next is testing for the other risk factors. So as we saw that 360-degree laser group had more patients with PVR at baseline. They were employed for more macula of detachment and silicone oil was used more. So each clinical factor was tested for its own Cox model to see if by itself it affected the redetachment rate. Does this make sense? If any doubt, you can stop and ask me in the meet. Okay. So independently, they wanted to assess all these factors, if they independently also affects the redetachment rate or not. So all these factors are assessed and hazard ratio are calculated for each of the factors. So as you can see here, primary PVR, macula of silicone oil use, age more than 60, gender of the patient and phacoemulsification when combined with vitrectomy. All this had an individual hazard ratio calculated. P values for each are mentioned here. And you can see if the hazard ratio is more than 1, that means that it is associated with increased risk of redetachment. And the green one, which has a hazard ratio of 4.41, which means that it is protective against redetachment. So then that study, they found that doing phacoemulsification with vitrectomy was protective for redetachment. So here you can see the highest hazard ratio is for primary PVR, which is 2.15. So it is twice as risky compared to normal. But still it is univariate analysis, so this is still unadjusted. So now they perform multivariate analysis. This helps control the differences between patients. So each patient is different from the other patient. You cannot have a similar detachment in two different patients. So this adjustment will help us understand if this previous result still holds its value or not. So what they did is they found after adjusting that these risk factors, 360-degree laser group still had a lower risk compared to the other group. So adjusted hazard ratio from 0.44 came down to 0.39, but it is still protective because it's less than 1. So now this is the adjusted, this table is taken from the article. So now we can see almost the same parameters that I showed you before. They have tested again, and this is the adjusted hazard ratios. So you can see the values have come down significantly. What PVR used to show 2.15, now it has come to 1.0. So it is not either protective, not also risk. But the intervention, the endolaser encerclage shows 0.39% hazard ratio. So what are the notable changes when the analysis was changed from univariate to multivariate? Univariate only takes in account the characteristic that you're testing. Multivariate also takes the patient into the account. So the primary PVR lost significance. It was increased risk, but now it came as neutral. Macula off became borderline. Female sex remained significant, like it is risk to redetachment. I don't know why. And 360-degree laser had effect straightened. So it still is protective compared to the localized group. So it is 0.39, which means 61% risk reduction compared to the other group. So after this much of discussion, now you can see that doing 360 degree may be a protective modality for the patient. So this is what they wanted to say. What else did they do is they did logistic regression. This is more into a complicated territory. This helps to predict the chance of redetachment as simple yes or no outcome. So this is like in PSM used to make the 2x2 table and do chi-square test and t-test. This is same. Using chi-square or Fisher exact, you can get this yes, no and the significant p-value. So this is again the table. This is just a separate analysis. It does not affect the outcome and what the article wanted to say. So they tested the number of PVR patients with redetachment and they stratified by local retinopexy or encerclage. They did the Fisher exact test and the outcome was not significant. So PVR did not affect the outcome of PVR was not affected by doing either local or 360-degree laser. Now they also tested for surgeon effect. As I said, 973, not a single surgeon was performing the surgery. 6 surgeons performed. Each person has individual preference. What tamponade they want to use, what kind of laser they want to do. So all this affects the outcome. So they tested for this and they did something called interclass correlation coefficient. It was like 5.1%. So it was still within acceptable range. And so differences in outcome were not due to the surgeon. And they did additional sensitivity analysis. This is all outside the purview of our lecture. So now when you understood all this statistical methods they employed just to rule out any confounding, any bias out of their outcome, and finally they wanted to conclude that 360-degree laser has 61% less risk of redetachment compared to the other group. So now we go into the mechanisms. What is the 360-degree laser? How does it help and how does it help with surgery? So history of retinopexy. So it all started in the around 1920s, where Jules Gonin established that retina breaks were the cause of the detachment, and they did thermocauterization through the sclera. So scleral incision, and it achieved a success rate of 30-40%, which now with technical advancements we are almost at 90%. So this is the diagram of ignipuncture. It's a needle which I think is connected to a heat source, and through the sclera they cauterize the break. After that, diathermy came into the play in around 1930s to 50s, and Ernest Custodis pioneered the segmental scleral buckling without the drainage, but it caused full thickness scleral necrosis and other complication, unpredictable scar, more redetachment, other breaks. So now we don't use it for retinopexy. So yeah, as I was saying that diathermy tended to cause full thickness scleral necrosis, so it was used, but now it is not used anymore. For other purposes, we still use diathermy. So this is the picture of diathermy. You make this thermocoagulations around the area where you need treatment. After that, cryo came. Sir Harvey Linkoff's seminal work in 1964 demonstrated that cryotherapy, which is a cold necrosis, so it is not heat, it uses cold, that it could induce adequate chorioretinal adhesion without scleral complications, and it revolutionized the field of retinopexy. And now we use argon laser or other laser. Its widespread clinical adoption was in 1970s, and Robert McCammer, now that partial vitrectomy that we use, first introduced the use of endolaser, and it became the preferred mode of intraoperative retinopexy. So this is a picture of a 360-degree laser. You can see, I'm not sure if it's clear, this is written ora secunda. So it means it creates another barrier where the retina is strongly adherent. And you spare the long ciliary nose here and do 360-degree. So the concept of prophylactic 360-degree laser treatment emerged gradually, but it is very recent compared to the other modalities. Initially, it was reserved for cases with unidentified breaks or a giant retinal tear, where comprehensive peripheral prophylaxis seemed logical. But some surgeons began applying circumferential laser more broadly. So initially, Coe and colleagues in 2007, they compared 115 eyes receiving prophylactic 360 laser versus 105 controls, and they found that the former group had 3.5 versus the later had 13.3% of redetachment rate. And this compelling finding catalyzed the interest in routinely performing this kind of 360-degree laser. So, as Dr. PDS sir was asking, we have laser, cryo, and diathermy, which is historical. How does it work? So, what is the pathomechanism of laser? So, through laser, we selectively is absorbed by the melanin of the RP and choroidal melanocytes. It causes generalized hyperthermia, so the temperature increases. This thermal injury triggers a cascade of biological events such as protein denaturation, coagulative necrosis, and disruption of the photoreceptor outer segments and inner retinal layers depending upon the laser parameters. So, how deep the penetration is depending on that. This stimulates the inflammatory response characterized by breakdown of the blood retinal barrier, influx of the inflammatory mediator, and activation of the mural glial cells, which forms the fibrotic scar. So the temporal evolution of the chorioretinal adhesion, it follows a biphasic pattern. First, the strength actually decreases immediately after doing the laser for around 24 to 48 hours, and post treatment it also increases again. So this decrease in the strength is due to the chorioretinal edema and cellular infiltration. So sometimes during this period we can see, after doing extensive laser, PRP and everything, we can see choroidal effusion also. So choroidal effusion is nothing but breakdown of the blood retinal barrier. It causes exudative swelling. So all this is from the seminal work of Dr. Kane in 1984, where he revealed that after this weakening of the strength in 24 hours, it returns to the baseline by 3 to 4 days, and then significantly enhanced day by day till 7 days, achieving a maximum strength of 2 to 3 times of the original by 2 to 4 weeks. So this temporal vulnerability during the first few days post-treatment has critical implications for tamponade selection and post-operative positioning. So around 2 to 3 weeks after any surgery, we give post-operative positioning. So other thing is that optimal laser parameters balances the adequate adhesions. So study confirms that a large spot size around 200 to 500 micron, anyway in our endolaser or LIO, we can't adjust the spot size, but it is fixed around that 200 to 500 range. Medium to high intensity produces a visible gray to white burn, and double or triple rows of confluent laser provide superior adhesive strength compared to single or subthreshold application. So this is the mechanism. You should apply at least 2 to 3 rows confluent, not overlapping.
So what's the difference between the cryo and the laser CRAs? Which is stronger?
Cryo one is stronger, sir.
Okay, which takes time?
Yeah, it takes around 4 weeks to come into play. Exactly.
Compared to laser.
Yeah. So just coming to that, cryotherapy also has similar mechanism. It induces a chorioretinal adhesion through tissue freezing compared to heat. And subsequent inflammatory scarring, application of cryoprobe to the external scleral surface creates an ice ball which expands through the sclera, choroid, and retina full thickness. The freeze-thaw cycle causes intracellular ice crystal formation, cellular membrane disruption, microvascular thrombosis, tissue necrosis, all that. Unlike laser, it does not depend on the pigmentation, and it allows effective treatment even if the eye is not heavily pigmented or the pale fundus. So it is more intense compared to the laser, greater blood retinal barrier breakdown, so more inflammatory chances, increased protein leakage, and more robust cellular infiltration also. So after seeing the mechanism and the overall outcome of the study, now we'll see the general consensus, what all other literature tells us about how to approach these kind of primary retinal detachments. Do we do 360-degree laser or do we do localized treatment? So this study, as we all know, with the data 3.9 versus 8.5, all these were the confounding factors such as PVR, macula status, tamponade type. But this article exists within a landscape of conflicting evidence. So large multi-center study have also been done, prospective randomized trial, retrospective studies, everything, and all this data is a little conflicting. So as I mentioned, this study, which was one of the first studies which demonstrated the use of 360-degree laser compared to normal. So these are all the studies I have that favored the 360-degree laser. As you can see here, the sample size ranges from 48 to more than 500. In early studies by Ivase et al., they used cases like macular hole also, instead of only using for primary rhegmatogenous retinal detachment. Most of them are retrospective studies. So retrospective studies again do not hold up that much value compared to a multi-center prospective study or a RCT. Type of RD in Ko et al., they had vitreous opacities. Again, it is not a kind of ideal cohort to compare with to our article. They favored 360-degree laser. Their outcome is also mentioned here. Most of them have the outcome that the redetachment rates were reduced compared to doing just a localized retinopexy. Yeah, one interesting finding in this article of macular hole versus rhegmatogenous RD, that the combined phaco-vitrectomy. They did a combined phaco-vitrectomy in all the cases, and it showed that macular cases showed significant recurrence reduction with 360-degree laser. So here it's another controversy that they employed 360-degree laser even in absence of rhegma or retinal break. And the study's outcome was showing that it was significantly reduced risk. So again, this is still retrospective analysis. And all these studies favor focal barrage. Not that the focal barrage were noticed to be superior compared to 360, but doing less is always better compared to doing more. So here we have 4 studies, one of which is a large multi-center interventional study, which has around 2,248 surgeries done by 61 surgeons. So I hold this as one of the superior studies compared to the others, and it showed that there was no difference between the groups. But when controlled for case complexity, 360-degree group had a lower final anatomical success and worse final visual acuity. So which is in contrast to what our main article, source article, was trying to say. So again, after all this discussion, we are still back to square one. We don't know what is superior and we don't know what is better to do. So this is again the graph of all the studies showing redetachment rate. In the study by Zhu et al., this redetachment rate is similar to the primary success rate. So in localized group, around 55% patient had 45% patients had redetachment compared to 360, only 10 or 9% patients. And this study by Stuchel, this is their source article, it shows that around 3.5 and around 9%. So above all this is meta-analysis. A meta-analysis is by Soekamto et al. Attempted to resolve this conflicting evidence by examining 6 studies. So out of the 10 studies that I showed, 6 studies were included in this meta-analysis. Their meta-analysis demonstrated that prophylactic circumferential laser produced no significant effect on the initial redetachment rate or the final best corrected visual acuity. However, in subgroup analysis, considering studies using only 23 gauge revealed that attachment rates were higher while doing 360-degree laser. This finding suggests that the protective effect from circumferential laser may manifest specifically within a small group where we use a small gauge vitrectomy like 25 or 23 gauge, and where complete vitreous based dissection and visualization is not possible or not done, compared to in a 20 gauge setup when doing scleral buckling. So only for a particular characteristic this outcome was significant. The meta-analysis highlighted the fundamental heterogeneity in the study population, surgical techniques, surgeon preferences, case complexity. All these factors affect the definitive outcome. So before concluding, I'll just go through an in-house consensus. So when Google Form was shared among the VR consultants, and I gathered responses from all of them. I wanted inputs from the consultants also here. Some scenarios where what to be done, where we are met with such scenarios, and I think it will help all of us to plan things better in future. So I open this segment for discussion for everybody. So this is the result from which one case in which of the following clinical scenarios only doing localized treatment of regma is justified. So where would you only treat the local breaks, not 360 degree? So most of out of all the 10 responses, most of were divided among these three scenarios. So when you have an acute retinal detachment with single primary break, it is justified to do only local treatment. Either you have focal limited or subtotal retinal detachment, again same thing, and around 40% said that it is a varies case to case. So should I go through all this and after discussion, or so what are your inputs here, ma'am?
No, not about this, about the journal.
Oh, okay.
Yeah. I just wanted to know the cause of redetachment in each group. Was it a missed break? Was it PVR?
No, so
I think that itself will tell you what turned the tables. Because I think that is probably the most significant thing which is missing. Which I thought was missing. That's why I just wanted to know, because I probably didn't read it in as much depth as you did. But it's not mentioned.
They haven't answered that question.
Yeah.
I think that's the most important, right?
But they're assuming that most of the surgeons are highly experienced surgeons. So they will not have all these
chances of misbreak.
reasons. But
No,
they're not.
or a new break.
Yeah.
Is if that is not mentioned, then a lot of your analysis is, was it PVR or was it a new break? Then your justification for doing a particular procedure in terms of causing reduction in the rate of redetachment, which I think is a very significant thing that's missed.
So again, the new breaks and everything depends on ultimately I think PVR only. If
No, you can have macular hole, right?
No, I think that.
Yeah, because that's what I meant. You do 360 degree laser, but you develop macular hole.
hole.
I mean,
Yeah.
how does it prevent?
Again, assuming that they don't miss a macular hole.
No, it's not a macular hole, but macular hole leading to an RD.
Yeah.
That's the point.
So they have not answered that.
I think that's an important question they did not answer.
Yeah.
Did they mention the time of the recurrence, whether it was an early recurrence or a late recurrence?
Yeah. So they from individual case they mentioned the date. So around from third day, some patients started having redetachment, and some patients around 1 year. So the mean time was around 28 days.
Okay, so the early recurrence you can attribute to a new break or a missed break. PVR obviously will not develop so early. But 1 year later, I don't know how that is connected with, meaning you can have a new break anytime later, but that is very difficult to, attribute it to a missed break during the surgery or
They
something.
also didn't mention if oil removal was performed. So maybe oil removal can also cause maybe a cause of a redetachment occurring at that late. But they have not mentioned that also.
Okay. No, but even if you don't take the oil removal, say if you have a primary retinal detachment where only gas is put, in those cases also you can look at the time of recurrence.
Okay. So any comments on this, sir? So is this correct? Like in such cases, can we employ a focal laser treatment? Like if we have a single break or a simple RD, subtotal RD, maybe not involving macula, is it justified to do just focal treatment to the break?
Your questions are too simple. That's why the answers are not going to be
No, sir. We are fellows and we have a lot to learn.
This question is too simple because when you think about a localized treatment, you look at the total clock hours of detachment.
Yeah.
You look at the timing at which the detachment presented to you.
Yeah.
You look at maculas attached or not. So many things you look at, and then you say, "Oh, this is a small break." Instead of doing, well, you tell me what is the alternative. The alternative is doing your pneumoropexy.
Yeah.
So or the alternative is doing buccal
Okay.
treatment. So there are so many variables. No, it's not easy to. That's why case to case base is fine.
Okay.
Actually, you can decide about that.
I think questions are not framed properly. I think. So for everybody will fit as a case-to-case basis. Most majority thing,
Yeah.
you let all the options open for all of us.
Just some clarity that I wanted for us fellows. So this is one question that I have. This, in case of no identifiable primary break when we are doing vitrectomy, what should be the preferred approach? Do we put encerclage and do a focal treatment? Do we not put encerclage and do focal treatment? And vice versa. So most of the consultants agree that doing encerclage with a 360 degree.
Yeah. See, focal, again, the question is, when you do focal treatment, you know the break.
Yeah.
When there is
If we are making retinotomy and then.
Yeah, but suppose retinotomy to drain.
Yeah.
But primary break somewhere has to be there from, that's why RDS.
Yeah.
And if you do not know break, where you are going to do focal laser?
Just the retinotomy.
But then you are missing somewhere peripheral break. The original break, primary break you are going to miss. And because you do not know primary break, naturally you are going to do 360 degrees. That's why everybody answer that like that.
So with encerclage or without encerclage? That is another.
Then obviously encerclage definitely. But definitely we don't know break, that's a 360 degree encerclage. That's why all of us answer like this. Probably.
As a convention for you to finish the fellowship and then start, take this conventional as the thing.
So
if
that
there
is
is no primary break,
Yeah.
you do a drainage retinotomy, you do the laser there, but still you cover 360 degree with the laser, and to have one more additional effect, pass the belt buckle and then make it safe.
Okay.
This is the teaching what normally teaching goes. Based on the case to case, you have a difference, but this will be the normal conventional way.
Especially if you're leaving the eye phakic, you're not removing the lens, your visualization is not clear. You may want to add the support of an encerclage. Whereas if you have, say, an aphakic eye where everything is crystal clear, then probably you do not want to do an encircling band. So I think there are a lot of things comes down to experience and your comfort level. And if you're leaving behind a lot of vitreous and then doing 360 degree laser over that, then that's a recipe for it will cause contraction, especially if the vitreous base is adherent. So there are a lot of other things coming into the picture.
Again, when you do vitrectomy particularly, this scleral buccal, you have a media haze, other things, there is a possibility you may miss the break. But that's the biggest advantage of doing vitrectomy. You clear the media and then you see, again, thoroughly examine properly. Most of the time, very rarely it happens. I'm not saying that it will never happen. Most of the time, you will be able to identify primary break. Yes, sometimes break is so peripheral, anterior, that you may not be able to drain through that, and that's why you want to have a drainage endotomy. That's a different ball game totally. But very rarely it will happen that you are not able to find primary break, particularly if you are doing vitrectomy. Exceptional situation is always there.
Yes. And this does not go like without saying that thorough peripheral depression and vitreous based dissection is
No substitute to that.
no substitute. Okay. So again, does the use of encerclage justify only localized treatment of breaks? So maybe in selected cases, irrespective to the feature of the RRD. Again, as the light is shed on this controversy also.
Can I give a comment here?
Yes.
See, the purpose of the encerclage is primarily to support the vitreous base, not to support the breaks. So, if you are leaving a vitreous skirt and if you are not doing base shaving, then the encerclage is a must. By chance, if there are any breaks in the periphery, they will get supported by the belt buckle. But if you have, say, prominent breaks or large breaks, then you have to anyway put a buckle element.
Yes.
So the encerclage is not going to support your breaks. So the main aim is to support the vitreous base and not for the breaks. So this localized treatment, I don't know. Even if you put an encerclage, you still may have to do laser 360 degree.
So with this question, which of the following features of the RRD determine the choice of barrage treatment? So, like most of them agree that the number of breaks and tears and the grade of PVR affect which kind of treatment that you will do. So, in case of more PVR, where you have more breaks and they are separated by multiple meridians, then it is preferable to do a 360-degree compared to localized treatment. Then again, this consensus and how strongly people are in favor of doing a 360-degree barrage in most of their cases. So they strongly feel that in most of the cases, again, depending on the case to case, 360-degree barrage is always better compared to doing focal laser. And again, putting encerclage also, most of them, almost half of them feel that very strongly would be done on all primary RD cases. And this last one, again to rule out any controversy in fellows' mind, is the choice of 360-degree versus localized treatment dependent on the tamponading agent. So most of them feel that it still depends on the cases, but I would like some comments that if you're using gas or suppose in superior RDs, or again, do we still do 360-degree treatment or?
Laser is for breaks, not for tamponade.
Yeah.
Tamponade supports after laser.
I think both your choices actually mean no
Hmm.
in a different way. Okay, if there was yes, then maybe.
No, yes was there,
Because
but
it's
nobody
no,
selected yes.
there is there is a yes. Okay.
So if anybody else has any doubt, they can ask at this point. I think we all have some doubts.
So, when you,
No, they have not put encerclage at all.
so you must,
Not. That is why I wanted to include encerclage in this questionnaire, so all of us know that putting encerclage is always better compared to not
That's
putting it.
probably their practice that they have analyzed. I don't think it
So
is,
all the patients that they had taken on all groups were without encerclage.
Any tamponade, any patient, no cerclage.
Encerclage at all.
see, primary pathology in a regard is actually vitreous. It is the vitreous which is dangerous. So if you're not able to do a good vitrectomy because of various issues, media is not clear, your what do you call, you are not as experienced in doing a thorough job, skill depression could not be done in those cases. So that's why people anticipate those problems and do a buckle. Otherwise you don't do a buckle. The buckle, as madam said, is just to support the vitreous base, because that's where the PVR is going to develop. Wherever you have left vitreous, the PVR member is going to develop that, and it initiate the process of detachment. Secondary break happens very close to where your vitreous is left over. It doesn't happen over a macula where there is no ERM, nothing. Simply it won't happen on a surface, is absolutely clear. It will happen on those areas where and most likely it always depends, because it's dependent, it remain on the dependent portion of the retina. And that's where so thorough vitrectomy is the only way to treat. If PVR is already set in, that's when you decide to go aggressive. Because a lot of times you have these folds in the vitreous base which you can't open, whatever you do. So to change the vector forces, you put a buckle just to put it back, and especially if it is closer to a break, very close to that. Or you ultimately, if you do the PVR is so bad, you ultimately do the RR. So the question is how the vitreous is behaved in the primary case, and then PVR, how bad the PVR was.
Macular status will not change your tamponade. Macular status only thing if you have macular hole or not. Okay, whether detached macula or attached macula, that really may not change your whether to decide different type of tamponade, or because of macula is detached, I will do 360-degree and macula is I won't do. I don't think it will just change. The same thing applicable to encerclage, what Dr. Chetan has rightly mentioned. Nothing to do with a phobia.
And please don't take belt buckle as a safety precaution. Belt buckle is nothing. It's just as what madam said. It's just only supporting the vitreous base. So if you're not covering your vitreous base with belt buckle, like for example, many times in myopia you're doing that. You attempt putting the belt buckle, and it is only supporting the aura, which is of no use to you.
Yeah.
So if you're not supported the vitreous base, then what's the point putting an encerclage? So the point is the buckle element is important to support that area. Say there's a break close to the vitreous space, still attached. The anterior edge of the break you are not able to clear. So whatever you do, you could not clear. You could not remove the vitreous. So, like for example, we had a discussion when we were inducing PVD. beyond the lattice, sometimes we can do. Sometimes it happens, most often it doesn't happen. So then, if you cannot clear the vitreous, and that is inferiorly, you will have to put a buckle then to support that large area, because ultimately that redetachment happens from those areas where the vitreous is actually there left over, and the PVR develops on that. PVR cannot develop on smooth surfaces. Develops usually on the surface where there is a lot of irregularity and vitreous. And most of the times you have lots of areas where the vitreous gets retained along the blood vessels at
Strongly different
the
areas.
aura.
Aura.
But basically, what Dr. Chetan is telling again. So that again adds on one more element. Like belt buckle, again repeatedly everybody talking about to support the vitreous base, posterior border of the vitreous base. Let me be very specific. So it makes sense rather than arbitrarily putting. Sometime you can just even localize because you want to support circumferential area. So not necessarily it has to be just 1 millimeter or 2 millimeter from the aura, or at the greatest circle of the globe, or at the equator, nothing like that. Probably makes sense to just, you really want to support, localize that and go along that area to ensure that it really support posterior border of the vitreous base. Okay, that's the way. So even myopic eyes, probably if you think too much of pathology, obviously vitreous is really bad, the aura, you still want to support, you always can go a little bit posteriorly. That is one thing.
So in cases where they have avascular retina, in all these cases where we put a eccentric belt buckle, so does it?
It is, one side maybe go a little bit posterior,
Posterior,
other side you can go a little bit oblique. So you can do that also. Obviously, you can do that. Also, this to make a thing simple as far as buckle is concerned. Broad buckle, basically, when you do scleral buckling, you always classically taught 2 millimeter on either side to cover that break, all area. So 2 millimeter either side means even if a tiniest break, you have minimum 4 millimeter you are covering, your belt buckle is 2.5 millimeter. So belt buckle is not meant to support the break.
Yes.
It is just what we are. So whenever you feel I want to support the break, always choose broader buckle. Okay. So don't say because there was break, I decide to support that with a belt buckle. Okay, so
that
it is
I
not
think all
covering
of
enough
us are clear
area,
about that.
and also we know over a period of time it migrates anteriorly or posteriorly depending on how. So the support will be lost over a period of time. Okay. So whenever you want to talk about supporting the break, always talk about buckle. When you talk about supporting vitreous base, posterior margin of vitreous base, then belt.
So when you see a case, you first see whether the age of the patient. If there's that this is a child, you are and it is a primary RD, not much PVR is there. You know that when you decide to detach the hyaloid, you may be successfully able to detach all the way up to the aura, except for the area where there is a break. Suppose there's a lattice. But if there are multiple lattices which have caused this, you can never detach it up to the aura. It's not possible at all. And this is a child. It might not be positioning itself properly.
Especially in
so these are the risk factors. So then you decide to put a belt buckle because much better. But if you have a large area, which like for example in FEVR we have large areas of vitreous which is not detachable at all, then you put a buckle element also. So each is case to case basis. An old person, you're operating in a 70-year-old, the vitreous base is already migrated posteriorly. So you cannot, whatever you do, you cannot detach the hyaloid all the way up to the aura. So it will be somewhere up to the equator. But there are no breaks in the periphery in those areas. So you do good base shaving and maybe just do laser, but not necessary to add a belt buckle to it. Only to the area you have a single HST somewhere in the periphery. You just add, if the HST is inferiorly, then you want to add a buckle to it. We are conveniently using belt buckle. People use segmental buckle like that. We conveniently use because we don't want to go through the hard work of putting a buckle there. Take a suture, put a buckle. We conveniently go through belt buckle route, but it's not necessary. Point is that.
Just have a couple of questions for our PGs. One of you can tell what exactly is the vitreous base and why is it important? Anyone? How would you define the vitreous base? So everyone, we have discussed so much, we are supporting the vitreous base, we are doing this, we are doing that. What is the vitreous base actually? This even first year is okay. This is not seniority because this is anatomy question.
It's the strongest attachment of the vitreous, ma'am.
Okay. And where is it actually?
It's
What is the extent and why is it important?
From the ora serrata around 2 to 4 mm.
It goes up 2 to 6, it's actually.
Okay.
Okay. So 2 to 6 is the firm attachment of the vitreous base around the ora serrata. Why is it important?
During vitrectomy, it's important to shave.
Before vitrectomy? No, it is important. Yeah, but why is it important to shave that vitreous base? Why is it important? What is the problem that occurs at the vitreous base? There's someone in the middle also.
Vitreous contraction will occur if we don't shave it properly, and then that.
No. We are deciding to shave it because it is prone to some problem, but yes, vitreous contraction can occur if we don't remove it and we do laser over that and patient develops inflammation. Yes, it can contract. What else? Why is it so important? Anyone? First chance is for the PGs, then we go to the fellows. And that's also a reason why we do 360 degree. Yeah. Anyone? Before we move to the seniors. It's a very simple question I'm asking because we listen to so much about it, no? Yeah.
The traction at the vitreous base may cause a retinal tears, further retinal
Okay,
tears.
yeah, because when PVD occurs, one of the areas where you can get a break, because you need PVD, you need the vitreous to liquefy to cause a break, and vitreous base is where most of the breaks occur. And if you see 1, 2, 3, there are likely that there will be more. And that is the reason you do your 360 degree laser, because and specifically mentioned near the posterior edge of the vitreous base. So there's no point doing, some of you may have seen patients coming with some 2 rows at the equator and all lattices detached anterior to it, right? So your 360 degree laser is to support that area because you may not be able to shape the vitreous fully, and that is an area which is prone to develop break formation, and that is why you do laser there. Okay? And so that's the whole purpose of this journal article. Very nicely analyzed, Sarjak.
So I have some few slides. Sorry.
You still have slides?
Yeah. If time is not a constraint.
No, go ahead. Don't
Yeah.
have statistical concerns.
So yeah, out of this article, what are the concerns that we have? That the 76% power analysis, that it is not enough. We need some more cases to justify.
What do you want? 80?
Around 80 to 90 is the ideal.
It's okay. 76.
The confounding by
Because
indication.
they have assumed no 1/3 will.
Yeah,
So that assumption is there. So if you put an assumption like that, then you'll obviously get a number like that.
number like that. Yes.
Don't put we say 50%. Then you'll need to have a very high power.
High number. 2,000, 3,000.
Yeah, so that is the reason. They assume something, no? See, everything is because of your assumption or a previous hypothesis which you're trying to correct.
Then confounding by indication, because some surgeons would choose some modality over the other. Baseline difference is also, some PVR was higher and the use of silicone was higher in 360 degree laser group because they were more complex cases. And some unmeasured variables which can contribute to the residual confounding, like extent of detachment and number of breaks. Surgeon variation also was there, 4-4 variation in redetachment rates. In one surgeon, least was 3.2% and one surgeon was 13%. And the use of laser also varied. Some used 3.4% cases only, and some surgeons in most of the cases use 360 degree laser. Another thing is safety concern. So theoretically, 360-degree laser should raise the concern of more inflammation and more consecutive PVR. However, no evidence of increased PVR formation with 360-degree. So they did mention, they did monitor the PVR, but they did not include if any missed breaks were there or any new breaks were there. The limitations of this assessment is that there are very small number of PVR cases were there. It was a retrospective assessment, and survival bias is also there. Like they analyze only redetachment cases having PVR, not all cases having PVR, and no systematic PVR grading, which varied among the surgeons also. So, what are the strengths of the study? Having a large sample size, real world data in a tertiary referral center, 4 years of study duration, and 1 year of follow up. Multiple surgeons enhances the generalizability, and comprehensive follow up with rigorous statistics. Weakness, it being a retrospective design, non-randomized, so no treatment allocation control was there, and randomization. The study was driven by surgeon preference. Selection bias was also there. Sicker patients would have 360-degree laser, and confounding by indication, which is the weakness of doing this kind of study, because it all depends on the intraoperative decision, and no blinding. So practical recommendation, as we all discussed, where in which cases you should employ, again this varies case to case basis, but this is general consensus, and in which cases you can go about with doing a localized retinopexy. So in high risk cases, usually no identifiable break, multiple breaks in different quadrants, inferior detachment, high myopic cases, prior RD in fellow eye, also high risk category, severe preoperative PVR, small gauge with phakic patient, giant tears, and limited visualization. In simple RDs, superior detachment with limited extent, pseudophakic eyes, good visualization, with previous history of doing barrages for other lattices, and uncomplicated cases, you can still choose a localized treatment because it's safer. Technical considerations. So when performing a 360-degree laser, place 2 to 3 rows of confluent medium intensity gray to white burns immediately posterior to the vitreous base. Achieve a gray-white burn. Consider slightly lower energy while going into periphery to minimize the down damage. Ensure complete coverage without any gaps, but avoid excessive confluency. And total around 600 to 1000. Again, it depends on the eye and case-to-case basis.
I have a little bit. This one. You says confluent, and you says avoid excessive confluency. What does that mean?
Yeah, like overlapping burns and very tightly packed.
Okay, because it's staggered. We need a stagger. We always need a gap. Confluent burn laser, generally we do not want confluent. Okay.
Yes.
So, and particularly you are going posterior to the vitreous base. And that exactly, I think Dr. D.A.D., I don't know who were there in a VRS, she discussed that one. Because you leave the anterior part untreated. You have a laser burn posterior to vitreous base, and tomorrow patient come with a break in that peripheral part. You have a ring detachment, posterior part is attached, and particularly eyes where you have oil, something, you don't realize that, and once you remove oil, patient will come back with those problems. I think that's a very, very important thing. Either you want to, if you are treating, go up to the aura, treat entire thing. Of course, after clearing all the vitreous and supporting, I would support in these type of cases, even support of encephalitis as well. But just don't do 2 or 3 rows posterior to the vitreous base and leave anterior retina untreated. That's more dangerous problem.
You have finished, Sarjak, or you have any more slides?
Yeah, sure. These are my references. And thank you.
Okay. That's actually, I do not see why it is a point of debate because the indications for 360-degree laser or no laser are very, very clear. So I don't think people will have any doubt in their mind when they're operating whether that particular case I should do a 360-degree laser or no. In the end, it is the question is, do you want a recurrence in this patient or no? Obviously, no. I am sure nobody wants a recurrence. I would rather have a patient with attached retina and let them have some increased inflammation or whatever ERM formation, doesn't matter, but the retina should be attached. So that is the primary goal. So for that, do you want to do 360-degree laser or no? I think it's a no-brainer. If you think there is a risk of redetachment, like you mentioned, all those high-risk things, then obviously you have to do 360-degree laser. Only in a very few select scenarios, like you said, very, very simple RDs with single break and all, where you are certain that there is no other breaks, then maybe you can just do some limited laser and leave. I would say that instead of doing this study for multiple surgeons and multiple case scenarios, maybe an individual surgeon should do auditing for their own cases, and for their own cases they can see that patients in whom 360 degree laser was done, how they fared, and patients in whom like they did not do 360 degree, what was the outcome, because it depends a lot on the individual surgeon's technique and how they are doing vitrectomy, how carefully they are doing, or how much vitrectomy they are doing. There are some surgeons who do complete vitrectomy, like base shaving, everything. Some people will do only posterior vitrectomy and not do much of anterior vitrectomy. So all those parameters are there. So I think that would be a better study than having.
These are the studies that I think most of them have single surgeon performing, apart from this report by Wong et al. Most of them were performed by single surgeons. Again, two different groups of studies. One favors that there is no difference, and other says that 360 degrees better. So again, randomized trial also showed that there was no difference between the two.
And the meta-analysis, what did that show?
Yeah, meta-analysis showed that it is only for a subgroup of small gauge vitrectomy where complete base shaving is not done. 360 degree has less redetachment rate, but again they have less visual outcome and visual acuity compared to the other group.
So one thing that you have to know that when the retina is detached and suppose the reattaches, that adhesion between the retina and the RP is never going to be the same as what it was naturally. So now when you put laser, you're actually enhancing that attachment. Even that is actually speaking 70% of the original attachment rates. You may say that it is 2 to 3% higher, but actually it's 70% still. It's not 100% as what it was naturally. So you are in those areas where the retina is already detached, you expect it to go back to its natural strength.
Photoreceptor to photoreceptor.
That bond is never going to be the same. So you add your laser. And when you say confluent, it is actually staggered. Sorry. So you have one row and then in between, the next row is in between, behind it, right? In between. So you don't do laser like you go ahead like white burns everywhere. So if you do just minimal burns everywhere, then you don't really expect so much inflammation.
The problem with white burns is the burn can create a break. Yeah. So confluent burns, especially in thin retina like myope, you will create a break, and you see third or fourth day you will see the retina lifting with the holes there. It will contract very badly. So definitely a grid pattern, and I would say don't even go to white. Yellow burns are the best.
Yeah, gray, yellow probably. Sometime when you do a laser, you get a burn, but you see something glistening over it, and you realize that it is deeper one. That is ideally should the outer retina and RP choroid should be involved in a burn, not inner retina. Okay, that's the ideal way. That's why. Now again going back with all these things, basically the purpose of laser or cryo PIXI is to seal the breaks. It really doesn't make sense talking about 360 degree or focal. It should be always not focal, localized area. Wherever you break, you want to seal the edges of the break. That is what you want to put a glue. When you want to stick something, so patch that area where it is leaking. But what happens when you have multiple breaks? When you have multiple lesions, rather, I would say, not break. Okay, different location, different areas. So even when you try to treat them, eventually what happens? You land up doing 360 degree when you have all around lesions, and that's why that 360 come into. But if you do not have breaks, other area, you are very sure the retina or aura or vitreous base is healthy. You really do not need. Now area where you can't see properly, you are not sure they are breaks or not, or you are likely to miss, and if you miss, naturally patient is going to come back with recurrence. So to give a benefit of doubt, you want to treat those areas because you do not know what is there and what is not. Okay, but if you are very sure everything is clear, right up to the aura to disc, everything you are seeing all around, and very specific breaks are there, you really do not need 360 degree laser. Okay, so keep that thing in mind. It's not like that because I just do 360 degree every case. No, ideally it should not be that. That's why everywhere what you have mentioned in your survey is case to case. Neutral, it should be, and take a call on that particular case. How well vitreous base dissection you can do. Okay, I mean, visibility, how clear it is. I mean, let me put an example. Previously, injury cases, when 20 gauge we used to do with a small lens, like a 20-degree, 30-degree field, and even prism also we never used to go. And peripheral vitreous we could never shave. And then you have a blood stained peripheral vitreous, and you do not know what is behind that, whether is there dialysis is there or not. Those cases we used to put encirclage, and you put 360 cryo, one row all around 360, because you do not know what is what. So if you don't want to miss, do it up blindly. So likely that you may be cover entire thing. But those are exceptional situations. We don't do now because in fact small gauge, and you are having a now better wide angle visualization system. You are doing much better job, cleaner job. And that's why belt buckle were there always in almost all the cases those days, because we never could see those area properly. So you wanted to compensate with something else to support it. So now you do a clean job, you see much more area. So you know exactly what is where. So take a call accordingly, case to case. Not blindly, because every case I'll do 360 degree. Eventually, certain cases having a lot of pathologies, obviously you'll end up doing it, but not like a blanket thing. You have like focal area, localized detachment, still I will go 360 degree. No, not really necessary. Because anything excess is bad. Laser is going to induce eventually inflammation. Left or vitreous going to contract further. In fact, you are planning 360 degree, I would say ensure that your maximum vitreous you are removed. In fact, with the vitreous there, you add laser, you land up in more trouble. Okay. So just always take a call. There's nothing like a fixed rule when science comes, medical thing comes, like everything is like a black and white. Case to case, always you take a call. Keep all options open always.
One word of caution for 360 degree laser I would tell is, when always leave a little gap, even though we say we have to go till the aura, because there's always a matter of burn creep and then ciliary body destruction and hypotony. So patient lands up with hypotony. If you're not careful enough, start lasering from the posterior base till the aura. So you can leave some gap so that for the burn creep or expansion and contraction to occur, then they don't land up. And obviously 2 or 3 rows, not lot of rows. That is one thing. Sir, I just wanted one more question, Madam, Sir. Whenever I put encirclage and we have a recurrent detachment, I find it easier to limit the RR when there is shortening and all that. The edges fall nicely over the belt buckle and we don't have to keep on extending. Like the traction is relieved. Obviously, we remove all the pre-retinal, subretinal, everything. But if we have a belt buckle, it falls easily, nicely, the edges, and you don't have to keep on cutting. So if there is no belt buckle, do you have any difference? Have you felt? In a recurrent RD?
I don't know how to put it. Basically, yes. Basically, what happened when you want to relieve the traction, even primary surgery, when you feel sometime you need RR, and you think I can support it, push the choroid sclera back inside, I may get away without doing RR. Obviously, because your circumference is reduced, surface area, you have pushed things inside. So probably RR can be much more anteriorly, not really that posteriorly. Extent may be reduced because buccal obviously there, so that helps you to, obviously traction partly, that is also helping to relieve the traction. Yes, in that sense, yes.
So that's why I find it quite advantageous to have a belt buckle in case.
No, for me, I mean, I say like what I was talking, but as personal choice, most of the regulations RDs, I still put encirclage most of the time. Okay, very, very exceptional cases, probably what you say, localized detachment, one single break to one quadrant or 1.5 quadrant, something like that. But because assuming that there is always pathology along vitreous base, and probably later on this contracting vitreous may create additional break, and you already supported, so traction is not there, traction is related to chances of having a new break, it minimizes. So as a personal choice I do, but that not necessarily I will say that everybody should do that.
Sir, in those cases you don't do 360 degree laser. Like you either put belt buckle
almost, unless I say situation described, almost as far as possible I'll try to avoid 360 degree. My laser is always to the lesions. Okay, not blanket 360 degree, never. Unless like a 360 degree pathology is there, then it automatically becomes 360 degree. But my laser is always localized to the lesions and encirclage most of the time. But again, it's case to case. I will stick on remedying that word. Anything, any doubt or no doubts or anything you would like to add? Enlighten us about something. Okay, then thank you very
Thank you so
much. Thank you.
think
A nice way of
Sarjak,
putting
very
it. I think,
nice.
see, this survey like thing, I think brings out lot of other additional thing also. I mean, good way of doing it.